First, thank you very much for this invitation to participate in the clinical workshop. I haven't been attending these meetings for the last 5 years or so, but being in Latin America, I couldn't resist being here. So this morning, we already talked quite a bit about the subject that was assigned to us. And this afternoon, Jose and Rolando, who has really been doing the work on cervical cancer prevention, already told you a lot. So I will probably say the same with the different words. So we were practically given the same subject for the 4 or 5 talks, so that we will have different views on the same thing. This was one of the issues that I was asked to talk about, challenges. So I had listed here what Jose already told you, well, the burden of cervical cancer with a very high difference between countries and within countries. For screening, what already you had heard here, that well-organized programs really are not that easy and not that cheap. And these programs should be tailored then to the socioeconomic conditions of the countries. And finally, we will tell you a bit about the vaccination, and the challenges with this are mainly the price of the vaccine. It's not easy to immunize adolescents with 3 doses, as there are competing demands from these countries. So you already had seen this. The burden is especially high in developing countries. I was asked to focus in Latin America. So these are the figures from GloboCan 2008, showing that cervical cancer is the second or the first in most South American countries. You see Peru, Bolivia, Guyana being still the first. The other countries is the second most common cancer, and it's only in Argentina, in Chile, and Uruguay that is number 3. So there is variation between countries, but also within a given country, there is a great variation. As you see here, the map of Colombia, showing in the darkest areas the highest incidence, the same in Argentina, highest incidence in the north, in the south, and also in Chile. Most probably, you will hear about this in more detail as people working in these countries are attending this conference. So, concerning screening, want to stress again that the programs should be tailored to the socioeconomic conditions in the various countries or regions. And from this point of view, I was interested in looking into the degree of inequality in Latin America. This is a recent article in The Economist showing that the measure of inequality is this Gini coefficient that's supposed to be growing globally, but in Latin America is one of the regions in which appear to be going down in the last 5 years. But of course, this is a very broad assumption, because in Latin America we had several countries that do better and others do not that good. And here I had put in graph the less unequal countries. Sweden is being the one with the lowest Gini index. Here inequality is less, and here you have Namibia, that is the most unequal country with an index over 70%. But you had here Haiti, you had here Bolivia, Honduras, and Colombia, my country, is number 10 in inequality in the world. So this is something that my colleagues in the Cancer Institute of Colombia are taking into consideration to formulate these control policies for cervical cancer. And we already heard here what Jerónimo has been doing on the visual inspection. We know that, as Rolando mentioned, the PAP-based screening programs are difficult, and most countries should be then that have the facilities thinking of planning to switch to HPV. But we had to consider, as Rolando mentioned, that follow-up of treatment of the lesions is the key to success in any screening program. I put here some of the countries that have programs on the low technology. Here, probably many are missing. And HPV testing, for example, here we don't have Peru, but Colombia has just approved the HPV testing as a primary screening method. I know that Caterina Ferrecchio is trying to do the same in Chile. So profiting that I was in Colombia recently, I had the opportunity of visit the interesting projects that the Cancer Institute is doing there. So I will tell you that a little bit after. For the vaccine, we had put together in the chapter for HPV Today that Xavier Bosch and Rolando had produced and that you have in your bags, this chapter on introduction of HPV vaccine. And in this slide, we had the countries that have national programs on HPV vaccine, and you see there are 39 countries, but look here, no one in Africa, and very few in Latin America. So that's a big challenge. In colors are the vaccines. Gardasil is blue and Cervarix is pink. And you see that these two vaccines are used in different countries. For the mini chapter I wrote for HPV Today, here I summarize the countries in Latin America that have the national programs. And so we had Mexico, we had Panama, Peru, Argentina, and lately Colombia. These are the main characteristics of these programs. As you see, most of them are targeting girls around 9 years of age. Most are using bivalent vaccine. Colombia and Mexico are using both Gardasil and Cervarix. Most are using a school-based strategy. In Mexico, there was the program that started as early as in Panama, but it was a regional program initially, and only this year, Mexico has decided to go for a national program. I just heard that Peru has discontinued this national program. Carlos Santos was telling that probably it's because they say there is no cost effectiveness studies, but he believes this is not the real reason as there is this study. So this is a real pity that this has been discontinued. You had the coverage here, and you see that for the first dose is very high. And for the third dose in Mexico is 85%, for example, in the regional program. In Panama is 68%. I was invited to participate in the launching of the national program in Colombia 3 months ago. And I was recently there, and I tried to suggest to the Minister of Health to consider switching from the free classical scheme of the quadrivalent vaccine to the scheme that is being used in Mexico, the standard regime, as well as this regime that is being used in Canada. And so this is, they were very enthusiastic with this proposition, and they probably will do so. As I tell you, I was trying to get more information in Colombia, and Raúl Murillo, who is the director of the Cancer Institute, invited me to this, to visit one of the most interesting projects that they have in a very remote area. Raúl has made a very comprehensive study evaluation of the cervical cancer prevention in Colombia, and they identified that one of the main problems was low access to regular care in some areas, and in other areas was the problem of low quality cytology. And therefore, they are now applying these two strategies to different regions of the country. The low care, the low technology, and the strategy see and treat is being used in these 7 areas that you see here in blue, that are remote areas, very difficult to access, and the HPV as primary screening is being used near Bogota, in Cundinamarca and Boyacá. The 7 areas where they are using the VIA screening are here in these circles, in the Guajira, in the Pacific Coast, in the Amazon, and I had just the chance of visiting this project in the Amazonas. Well, to go there, you had to take a plane from Bogota and 2 hours flight, and then you reach Leticia in the border with Brazil and Peru. And there, the main way of communication is through the rivers. There are no roads, so the rivers are the highway. The people move around. And of course, the main highway is the Amazonas. And as in every highway, you had a petrol station where the boats go to take petrol. This was in a small hospital in Puerto Nariño, in the middle of the jungle, where I was participating in this screening with a strategy of see and treat using VIA and VILI. And these are the women attending. They were highly motivated, very interested in getting the examination and also the treatment. Similar project is in the Pacific Coast of Colombia, in Tumaco. This morning, somebody was asking about quality control. Jose already said that the people who are going to do this examination has to be well chosen, to be motivated, and to try to stick to this examination. And in Colombia, Raúl Murillo has developed quality control virtually, and this is something that is really a very good method to try to keep these people trained at a high level. For the vaccine program in Colombia, well, it's very new. It started last August. They are planning to have a phase 1 that will be a school-based. It started in August. And in February next year, we'll start a community base for the girls who are not attending the school mainly. So they decided to have vaccination of girls in the 4th year of primary school, and this will be only girls that will be 9 years or older. And they believe with this strategy, most of the over 50% of this cohort of 9 years girl or older will be taken. So this is what they do. If they go to the school, they go to the 4th degree, and they choose the girls who are 9 or older. They had a very good plan of communication to first for the girls, for the teachers, and then for the parents. And just to end up, the last half a minute, another program in which I am a bit more familiar is the program in Mexico. And again, this is you will find this in the HPV Today for Latin America, in one of the mini chapters. What Mauricio Hernandez and Eduardo Lascano have formulated for Mexico. And perhaps it's interesting to go back to say that, well, they are now considering, as I say, primary prevention, vaccination in 9 to 10 years old girls nationally, and they already have distributed over 2 million doses of the vaccine. And the secondary prevention, they have in women 20 to 34 years of age, they do the HPV testing. 35 to 65 HPV testing, and the conventional cytology for the younger than 35. And well, they follow the algorithm that you had seen already. Just want to mention this last study that was done in Mexico, showing what Rolando and Jose Geronimo had said, that alternative of self-collection of a specimen for HPV testing, showing, of course, that this test is much more sensitive than cytology, as you had seen with all the studies. And Rolando and myself were invited by Lancet to produce this comment, and we decided to say that, well, Mexico is one of the countries leading in the region in prevention of cervical cancer, and with this study we can say that prevention of cervical cancer is in women's hands. Just to finish my last slide, well, it's 30 years ago that Gabriel Garcia Marquez got the Nobel Prize, and he in his speech was talking about the solitude of Latin America, and that we need more solidarity, not only with our dreams, but with our actions. Thank you very much.